You can see my slides, correct?
Yes, doctor. Yes, sir.
I have no
Yes, sir, we
financial
can see the
interest
slides.
to
Yeah.
disclose. Now, when you talk about suturing, I think for corneal transplantation, suturing is the most vital step because a proper suturing would ensure a proper wound healing. It would also maintain the graft clarity and give optimal refractive and visual outcome. As you see in the clinical photograph, this patient has undergone a corneal transplantation surgery 14 years back. And after suture removal, you can barely see the corneal scar at the graft-verse junction. And on the anterior segment OCT, the corneal curvature looks very good and very good apposition of both the anterior and the posterior aspect of the graft. So this is what we should strive to achieve when we are doing a corneal transplantation surgery. So what are the basic principles of suturing in corneal transplant? One, we want to oppose the wound edges in the normal anatomical position. When you do keratoplasty, ideally we try to oppose both the anterior and posterior, but yes, from the surface healing aspect, sometimes the anterior apposition is more critical. It should aid the natural healing process and minimize the scar formation at the graft-verse junction. At the same time, the wound should be secure to prevent any wound leak and thereby reduce the risk of infection. And the wound strength should be strong enough not to give away. And it should not induce significant astigmatism because you have a circular wound and you place suture all around. So the tension has to be optimal all around the wound. Now, when we talk about doing suturing and in corneal transplantation, there are some essential instruments that you need to have. You need to have corneal calipers. You need to have markers like the 8, 12, or 16 marker that gives you alignment mark and the starting point for the sutures. You have the surgical marking pen. In terms of the sutures that we use, you can commonly we use the 10-0 nylon, although mercilin has been described in literature, but still not very popular. Nylon is elastic, easy to handle. The only disadvantage is over a period of 1 to 2 years, the nylon starts degrading and then it starts breaking. Mercilin does not degrade, but the problem is it's a monofilament and it's slightly difficult to handle and it may require readjustment over a period of time. You need to have a needle holder. You need the colibri or the pierce skin to hold the corneal tissue. You can use the LIMS forceps or the Pollack forceps. We'll show the same. You see the Pollack forceps is the double-ended forceps. That's very critical when you take the first suture when you are doing a penetrating keratoplasty. For suture tying, you need the non-tooth, both straight and angled tying forceps, and you also need something to look at the reflex on the cornea, like an intraoperative keratometer, like the Maloney's intraoperative keratometer, to understand whether the tension is symmetric all around the graft. In terms of sizing of the graft, for normal indications, we tend to oversize our donor by 0.25 to 0.5 millimeter. And for the recipient bed, instead of using regular handheld trephine, if you use the vacuum trephine like the Hesper Baron, you will get a better configuration of the wound and a symmetric cut, which is much more vertical. Or if you have access to femtosecond laser, you can make shaped incision, which pretty much helps you fit like what you see with the carpenter. You know, when they are aligning the pieces together, they fit together like a jigsaw puzzle. So that's what we should aim for. The donor button can also be punched from the endothelial side using a endothelial punch, either the vacuum or the non-vacuum. And once you have punched it, keep it hydrated and in the BSS to protect the endothelium. So when you're suturing your graft, you can use a wide variety of techniques. You can use single interrupted sutures. You can use combined interrupted and continuous suture. You can use single continuous suture where you put initial 4 cardinal suture and then maybe a 24 bite running suture and the 4 cardinals are removed at the end. Or you can use a double running suture where you can use a 10-0 and a 9-0 10-0 and 11-0 to place the double running suture, usually 12 in 12. These are all various combinations that have been described and tried in literature. There are some advantages and disadvantages of each of them. Single interrupted sutures can vary anywhere from 10, 12 to 24, depending on the graft diameter. If you're doing in a pediatric case, if you put a 6.5 or 7, sometimes 10 to 12 sutures are more than sufficient. But if you're doing a 9, 9.5 or a 10 millimeter graft, because of the increased circumference, you may require maybe 24 or more sutures to ensure that the tension is, the wound is secure all around. The advantage of interrupted sutures are that they are easy to replace, and during surgery, if you make a mistake and you don't put the sutures the right depth or the right bites there on the either on the host or donor, you can easily replace them. Or if you make a suture which is slightly tighter or something which is not optimal tension, you can always go back and revise. Post-operatively, also a selective suture removal can be performed guided by the topography to manage astigmatism. A combined interrupted and continuous kind of takes the benefit both of the interrupted and the continuous sutures. The advantage of continuous suture is that it allows adjustment of suture intraoperatively to minimize the astigmatism. You can do that with the interrupted sutures as well, but then you have to, replace and reapply a lot of interrupted sutures to get the optimal circular shape. Whereas in the continuous suture, you can just, adjust the suture around the circumference, and by adjusting the tension, you can get the nice round reflex, and that can help minimize astigmatism. This manipulation can be done in the early post-operative period as well, if required based on the corneal topography. You can put the running suture with the taking the bites radial, or you can put them in an angulated like an isosceles triangle, which is called a no-torque placement, which you will see in the videos that I show you next. And a combination of 10 and 11-0 nylon can be used. And usually you start off with the 10-0 nylon, and this, which is usually at 90% depth. And then when you go on with the 11-0 suture, that can be placed a little superficial at 50 to 60% depth. And usually it's done like that because you don't want the first suture to accidentally cut the second suture to accidentally cut the first suture. So this is where the three main techniques of suturing that we use. Now, when you're handling the suture, it's important that, even when you take your throws on the angled tying forceps, in the first image that you see, make sure that you take it in a very symmetric fashion. Don't take it in a haphazard way that the suture. What happens is this does not allow a proper knot formation. You get entanglement, which is not great. And the second is that when you take your bites in the cornea, usually 1 to 1.3 millimeter on either side, but try to take a bite that goes close to the decimals, like 90-95% depth. Because if you take a superficial bite, it may oppose on the surface, but you get an internal wound gape, and the wound is always, with the microdehiscence, the wound always remains weaker. And this post-suture removal has a greater tendency for this part of the wound to bulge forward and induce more astigmatism. And if you take uneven bites on either side, that means you take a deeper bite on the donor and a superficial bite on the host, that will lead to overriding. That can also induce astigmatism. It can also lead to excessive scarring at the graft source junction. Sometimes you get a lot of epithelial hyperplasia because of this overriding, and you have unwanted appearance of the graft as well. Now, when you start off, you take cardinal sutures. These cardinal sutures are placed at starting at 12, then 6, 3, and 9, equal bite, width, and depth. And you also check for the centration. The depth is usually 90% of the corneal thickness. Now, one problem that you face is that when you do this suturing, the 12 and 6 o'clock sutures are reasonably easy to apply. But when you go on to the 3 and 9, because of the angulation, you find that applying those 3 and 9 sutures can be a bit more challenging. And sometimes they don't end up being perpendicular to the graft or junction. So one way to overcome that is that the initial suture, you need not apply at 12. You can always go little off. That means you can apply it at 10 o'clock and the other one at 4. Thereby, what happens, your next suture is at 2 and 8. So thereby, you still get your square or the diamond configuration, but it's easier to apply the way you hold your needle holder. It's easier. The other solution to that would be that you apply the first 12 and 6 seated superiorly, and then you can shift to the temporal position and then apply the 3 and 9, which is virtually like applying the 12 and 6. So thereby, you get very nice placement of the first 4 cardinal sutures. And I like keeping the surface a little dry because of the tension from the sutures. I can see whether I'm excessively tightening the suture when I'm applying my knots. So as we mentioned, the entry and exit is 1 to 1.2 millimeter from the wound edge. It should follow the corneal curvature. So basically, you look at your needle. You hold your needle 1/3 from the distal tip, between 1/3 and 2/3. That's where I hold with the needle holder. And I allow once the needle enters the cornea, it should follow the natural curve of the needle. So you don't really, so it should be a very nice curve which follows the corneal curvature. And when you tie the knot, again, we will come on to that. You can commonly, we use the initial first throw is 3 throws on the tying forceps, followed by the first knot is called the approximation knot. So what is the purpose of the first knot, whether it's 3 throw or 2 throw? It is basically to approximate the edges, and that decides how tight your graft-toes junction is going to be. The remaining 1 that you apply, which are usually applied in the opposite direction to the first throw, that is basically to lock the approximation knot that you placed. And you don't need to add more knot to it. You don't have to go 3, 1, 1, 1, add some more, thinking that that's going to make your wound more secure. It does not add any greater strength to your wound, but makes the knot very bulky, and burying that knot can become a little bit more problematic. A lot of people in the West like to use the slip knot, which is like a single throw. So the first 2 single throws are in the same direction, and that allows you to adjust the tension. And once you feel that the tension is optimal, then you can put the last throw in the opposite direction, and that kind of locks the knot. The only problem in this knot is that the first knot, when you put just with a single throw, it's sometimes difficult to keep. It kind of keeps slipping off, and then you put again the same. So if you're not very careful, sometimes the second throw can lock the knot, and then you're not able to slide it, and you have to go back and revise. Now these knots, whether you bury on the host or the donor side, there are some plus points on either. Burying on the recipient side gives you the advantage that when you remove the suture and your knot is buried, but you pull during suture removal, you pull the knot out, there is a less chance of the stress on the donor is less chance of the graft-toes junction opening up, especially if your knot is stuck in the wound. But if you have a big knot on the peripheral side, it can induce inflammation. It can bring in blood vessels to the graft-toes junction. So that's why it's usually recommended that you try and bury it on the donor side, which is far away from the limbus. So there's less chance of the graft-toes junction getting vascularized. Now let's look at suturing. If you see, so this is with the Polak forceps being held. You made the first pass 1.2 millimeter on the yeah, it should go about 90%. The video says 80%. You take the 3 throw, and then you can see that you're holding the suture, you make the pass, and then in the reverse direction. Always remember that when you're tightening the suture, it should move in the opposite direction, or it can be 90% to the primary suture that you've placed. So thereby, you don't over tighten the suture. If you are not very careful with your the way you're holding the suture, the knot forms, and then it can slip, and it can create further tightening of the original wound. Watch in this video as well. I'm holding the needle at 2/3, 1/3 junction. That's the Polak forceps. Again, it's going 1.2 millimeter, going 90% of the depth, coming out very close to the decimals. Again, going to the base of the wound, coming out again 1.2 millimeter on the either side. 3 throw, hold the suture, pull it towards you. The second throw, pull it away from you. The third throw, again, you can see that that's it. The video is running at twice the speed. I don't suture that fast. So that's how the knot, and you can see that if you keep the surface dry, you can see if you're inducing too many folds. If you're inducing too many folds radiating from the suture, that tells you that your suture is excessively tight. And so you should tighten the suture just that it approximates the wound. And remember that if you are suturing in an eye which is slightly softer, then when you form the chamber, these sutures will become more tight. This is a video of the slip knot.
Downward, pull the suture.
So you can see that that's the first throw. Then you have this in the same direction, you take the second throw. And now you see that you can tighten this. If you pull, it will become tight. And then if you want, if you feel it's excessively tight, you can always relax. You can, manipulate the suture to loosen it. And once you feel that it's in this, now you can see he's loosening the suture. So that's the advantage of the slip knot, that you can go back and you can adjust the tension. And once you feel it's the optimal tension, you can go in the reverse direction and apply the knot, and that kind of locks it in place. So you see that. So now it's optimal tension. You go in the reverse, and then you lock it. So now it's not going to slip. So this is again something that can be done. If you like using it, you can practice in the wet lab using the slip knot, and you can use it for your surgery, and that can help you better adjust your the suture tension when you're putting multiple sutures. Now, yes, you can use a mark on the cornea when prior to starting surgery. So this helps you put in the graft, and then along these marks, you can ensure that you place all your sutures symmetrically. You can get an 8, 12, or a 16, and ensure. The only advice I have to give is that before you apply the mark, dry the surface. Otherwise, the ink tends to get smudged. If there is any loose epithelium, you can even debride the loose epithelium and then apply the mark. Before you apply the mark, just apply the marker without the ink, and just to see, create an impression and be sure where exactly you want it. Because if you apply the ink and then apply the marker and you realize that it's not well centered, then again to reapply another mark may become difficult. And always wash out the excess ink. The problem is getting good marking pens. I usually like to use the marking pens that come with the toric IOLs. They are quite good. They are the viscot skin markers, and they are pretty good. Don't apply excessive ink as well, because that tends to smudge the cornea. And then sometimes it makes it a little bit difficult to visualize when you're suturing as well. So as a routine, my suturing is quite symmetrical. I go by a divide and conquer technique, where I place the sutures, and the next, after the 4 sutures, the remaining sutures are always in between the first 2 sutures. So thereby the sutures are quite symmetrical. But when you're starting off, no harm using one of these devices to mark the cornea. You will see in this video that we have marked the center of the cornea, then coming with this is the 8 marker. And you look at the centration mark and then apply on a dry corneal surface. You get those 8 marks, and then you can do your trephination, and these 8 marks acts as guide when you are applying your sutures. In terms of trephination, yes, as I mentioned, that you would like to have a very symmetrical edge of the host bed and the donor as well, because nothing like having a perfectly aligned donor and recipient. That's the beauty of using the femtosecond laser. When we use the femtosecond laser, especially shaped incision, we find that the donor and the host really fit very well. But when you are doing manual trephination, if you use a handheld trefine, you have to be very careful, because the pressure with that trefine is not symmetrical. So you can tend to cut deeper at one edge than the other. So the vacuum trefines are very good. And I like using both the Catena and the Moria trefines, and even the ones from Surgistar. In India, you get from Madhu Instruments as well. So they ensure that you get nice centration, and the cut is very symmetric all around. and makes it much more easier when you have a well-centered cut on the cornea. Now here you see that we have the marks. I apply the Hesburgh-Barrett vacuum trephine on the cornea. The crosshair in the center allows for centration. And once you're sure that your trephine is in the right position, you can go ahead and move the trephine. I don't go through and through because I don't want to damage the iris. So we go about 6-7 quarter turns. And once you remove it, you see that you get a very nice cut, which is circular and symmetric in depth all around. In terms of suturing, now let's look at suturing what we discussed earlier. As I mentioned, hold the needle between 1/3, 2/3. Don't hold right at the tip, slightly away from the tip. Take good bites, 1 to 1.2 millimeter on either side. Go 90% depth, and then ensure that you take a 3-1-1 and no excessive tightening, just approximate the wound. And now you see that this is the cardinal suture being placed. So we hold at the other end with a 0.12 colibri or a Lim's forceps, get your suture out on either side. This is again a 3-throw, approximate, ensure that the distribution is symmetrical on either side. So this is good. This is important. The second suture is very vital. So you don't see any gaping on either side. Then come back, take a bite at the 3 and 9. So the marks you can see are helping in terms of positioning the suture. Again, 3-throw, approximate, and then reverse. And then again, a forward throw, a single. That's it. That's a 3-1-1. You can cut with a vannas or cut with a slit knife or a sharp knife. That's perfectly fine. That's the so the 4 cardinal sutures are important. Whether you do single interrupted sutures or you do a continuous, it's important that the first 4 sutures should be placed properly. You can see the nice diamond configuration or the square configuration, and there should not be any excessive tightening on either side. This is after we place the remaining 4 sutures. I'm going to put a running suture, so I'm burying the knots from the. Now, in terms of the running suture, you can see that I'm going to put angulated. Let me try and see if I can. So you see here that this suture is not coming radial, means it should have come like that, but it's coming angulated like that and is going to go back like that. So it forms an isosceles triangle. That means this angulation and this angulation is the same. So you go like that. So the advantage of this is that later on when I'm tightening the suture, there is no distortion of the interrupted suture. That means the graft doesn't talk. It doesn't turn around as the sutures are tightened. Whereas if you do a radial suture, at the end of it, when you tighten your continuous suture, because the radial sutures will induce a torque, which can be clockwise or an anti-clockwise direction, depending on how you're suturing. The radial sutures, instead of the interrupted sutures, instead of remaining radial, can become tilted a bit, which may influence your overall induction of astigmatism. So you will see that we go ahead, and these need not be 90%. The running suture usually even 60 to 70% depth is good enough. And compared to interrupted suture, running suture has a better apposition of the donor and the host. This is running at 4 times the speed, so just to give a clarification. So you can see that you can symmetrically go. Just you have to be careful that you don't get your sutures entangled, and take your time, take the bites. If you want, you can even mark the points where you intend placing your sutures using a Sinskey hook, and just put dot marks on both the donor and the host where the entry and exit should be, so that you can visualize where your needle points are going to be, so that when you're placing the suture, you exactly know where you're going to go and come out. Without that, if you try to do it, depending on how you are holding your needle holder, you can have in certain quadrants, the suture looks very nice, but especially between 6 o'clock and 10 o'clock, that part for a right-handed surgeon, that part placing the sutures are not really great, and you find that your angulation tends to change, and then the suturing does not look very symmetric. In terms of tightening the suture, what you saw me do there, you can see that when I tighten the suture, this is where I'm going to tie the knot. So I go at the opposite end and I tighten the suture from there, both anti-clockwise and clockwise. So I don't go in a circumferential fashion. I start at 6 and I tighten towards the place where we are going to tie the knot. That kind of ensures that there is no rotation of the graft. Otherwise, if you go only in one circular direction, sometimes the graft can rotate a bit. Although if you are putting no torque suture like what I have put here, the graft should not rotate. And even before you tighten your final suture, it's always important that you normalize the eye pressure. That means I would inject some BSS into the anterior chamber, keep the chamber well formed, neither too tight nor too soft. And then I would put the final tension. Because if the eye is soft and you tighten the suture, your corneas can become excessive flattening, and then you find that your patient has a hyperopic shift in the post-op period. Once you're sure that everything is good, then you can, and this is where we use our keratometer. You can see that it's looking still fairly round. There was a little bit of a vertical oval. That means my horizontal sutures were a little tight. So I kind of pull the sutures from the vertical, from 6 and 12 towards the 3 and 9, kind of trying to loosen the tension in the horizontal axis. And once we have done that, now we go back, and if we check again the reflex, you find that the reflex looks a little bit more circular, although there's maybe a excessively loosened. So again, we go back. So you can do that till you get a very nice circular reflex and you're happy with that. And that's pretty much should be the end. You don't have to keep if you keep manipulating, you don't have to get a perfect circle. But I think something close to that. Now, if you see, this is the end. I'm very happy with that. And yeah, still not. Yeah, this looks good. Yeah. So this is the end point so that's the advantage of using a Maloney's intraoperative keratometer, that you can look at the reflex, adjust your tension. Although these tension, the tension can change as the graft dehydrates and settles down, but at least we should make an attempt at the end of surgery to try and leave behind a nice round reflex to the extent possible. That was what I showed you was a DALC suturing. Now let's look at PKP. The difference in PKP is that you have a open globe. Now, in an open globe, if it's a phakic eye, maybe sometimes you need not even apply your Fleringer ring, but make sure that your speculum is not overtly tight and there is no significant upthrust. But if you're operating on a deep set eye or a vitrectomized eye with a secondary IOL or a pediatric eye, so in those kind of scenarios, it's always helpful to put a Fleringer ring so that the globe does not collapse. Because in those situations, when you remove the post cornea, the wound tends to become a little bit oval. It doesn't, depending on the speculum that you've applied, it doesn't retain the circular shape as what you see in graft. And there, I think the mark that you put, the 8 or 12 or 16 mark or reference marks that you put becomes very important, because you can easily identify even if the wound looks a little bit distorted. Otherwise, sometimes once you suture your cardinal sutures and then you form the chamber, you have to again go back and revise some of the sutures. Now you see that we have these are the 4 marks that I have put where I'm going to apply my Trifine. I like putting that. That's an 8 millimeter Trifine. So I'm using an 8 on the host and an 8.5 on the donor. I like making a paracentesis because instead of accessing the anterior chamber through the graft hole junction, having a peripheral paracentesis is always good whenever you want to access the anterior chamber to inject either air, viscoelastic, or fluid. And when you're refining, before you do your complete removal, you always put in some viscoelastic into the anterior chamber. Now, before I open up the graft, This is a vacuum donor punch from Catena. This is the new one, which has the mark also. So that kind of shows you where you're exactly going to punch. So that's very useful to have that. I like these endothelial punch using an 8.5, 0.5 millimeter larger, and I can always see whether the punch is complete or not if I rotate the scleral rim outside the area of the punch. That ensures that my punch is complete. You gently remove, and you will see that you get very nice vertical edges. And this kind of, you apply some viscoelastic on the endothelium to protect, and then you can place using a patent spatula, you can put the donor back into the storage solution and then go back now to the surgery. Now remember that now my chamber is also having the viscoelastic that avoids any sudden decompression. It's important to have very good corneoscleral scissors as well. Try to keep your scissors vertical so that you can get nice, vertical cuts. There is no shelving or sloping. Although sometimes people like to make, especially if they have already done a 90% depth refination, the peripheral edge, they may want to leave a small ledge, which kind of acts like a support when you put in your donor graft. But that should not be the ledge should not be too bulky or too big, because that affects your apposition of the graft to a junction and can induce astigmatism as well. Now you see that I remove the post cornea, and then I realize there is a ledge. I go back with the Vannas and I trim out that excess ledge where I thought that it was looking a little bit more prominent. Now put in some viscoelastic before you put in your donor graft to protect the endothelium, and then we apply the donor graft. Now you'll see that the first suture is the most important. Sometimes you can rotate the graft to see which is the best approximation. Here you see I'm using a Lim's forceps, which is a tooth one. Get a good grip. Go in front, just in front of the tip of the forceps, and then pass your needle. That's 90%. Again, I put it on the host side, and there is enough viscoelastic protecting the endothelium, so the graft just tend to slide a little bit on one side or the other, but that's just on the bed of viscoelastic. Again, you will see that we go for a 3, and you just approximate, don't tighten excessively, and then the reverse, moving the time forceps in either 90 degrees to the wound or in the opposite direction. I just hold it the opposite, and if I stretch it, I can see, because you see a fold that kind of bisects the cornea, and it should be symmetrical on either side. So you again go 90%. So before you apply on the cornea, you kind of just apply the needle and see whether your graft is symmetrical or not. Again, a reverse 3 throw, then the single in the opposite direction, and then the final reverse. Again, you can see that now it's going to move, 90 degrees. So that's, again, applying the cardinal sutures. And once I've done with the 4 sutures, now at this point, instead of putting in viscoelastic, what I like to do is I always like to put in an air bubble in the anterior chamber. The air bubble, it's kind of helps maintain the contour of the cornea better, because you can see how much of air you are injecting in the anterior chamber. But when you use viscoelastic, there is no end point to the amount of viscoelastic you are injecting. So you can sometimes overfill, and that viscoelastic kind of comes out on the surface, and that also interferes with your suturing. It kind of gets onto your tying forceps, the suture slips. And now the remaining sutures that I'm going to put here, you have to try and see to it that your air bubble does not escape. So if you are not manipulating the tissue too much, the air bubble should remain in the anterior chamber. So you can see that we take bites in the opposite quadrants, again going 90% depth thickness and about 1.2 to 1.3 millimeters. So similarly, apply the first. Yeah. So that looks, so now you can see that I'm drying the surface. I can see on the dry surface that the tension in the sutures look very symmetrical. At this point of time, if you feel that the sutures are not symmetrical, you still have the option of adjusting that. Because if I'm going to use a running suture now, but my interrupted sutures are asymmetrical, the running suture will not be able to give me a very good, reflex at the end because the interrupted sutures are not symmetrical. So at times, sometimes we use the keratometer even at that stage, at this stage, before we put the running suture, just to get an idea that the overall distribution of the sutures are quite symmetrical. And the running suture is the same as what you saw in the dark. But like I say, that you can see that throughout this surgery, I'm not replacing that air bubble. That means my overall manipulation of the graft hose junction is not too much. And I think if you're going to improve your surgical skill, you should try and aim for that, to try and see to it that but it's okay. Even if the air bubble comes out, sometimes you can always go back and replace. And I like putting an air bubble because I don't put in too much of viscoelastic in the anterior chamber. At the end of suturing, I don't have to spend time trying to wash out all the viscoelastic. And because we don't use too much of viscoelastic in the anterior chamber, the post-operative IOP spike is also less. So you will see that we will finish our suturing in the symmetrical manner. And before I tighten the suture, I remove the air bubble, and then I'm tightening the suture. Similarly, I'm going from, I started at the opposite end, did the anti-clockwise. Now I'm doing the clockwise tightening from 6 to the point where 11 where I've finished. Once I'm happy with that, I've taken off all the slack. If there is any doubt, I can go back and do that the second time. But always remember to keep holding on to the suture because otherwise you don't get the slack coming out. Once I'm sure that the sutures are optimally tight, I go back and put in the 311 to close the. And remember when you're suturing that if you have any bleeding on the surface, always keep your surface neat and clean. That means if there is any, sometimes when you have corneas which have peripheral vascularization, even when you take interrupted sutures, tends to bleed. But if you continue to suture with all that bleeding happening, you can put bits and pieces of Merocell sponge in the area of bleeding. That kind of ensures that the blood does not interfere with your visualization or the suturing process. Now you can see that again, I'm going to use the keratometer and look at the reflex. And even the air bubble in the anterior chamber also gives you a clue regarding whether your graft tension is optimal. If you have excessive astigmatism in one quadrant, the air bubble in the anterior chamber will also take. This is the post-op day one. You can see that the graft looks very good, very quiet eye. Astigmatism management, we mentioned about the use of keratoscopy, and there is a new device developed by Remedio, which is a phone-based topography. So maybe if you can get your hands onto that, even intraoperatively, you can take a photograph with that phone and try to look at the topography. You have microscope-based illuminating light, circular light, that also maybe I'll show you in the next slide. So astigmatism management, also the selective suture removal post-op, or if your sutures are loose, you can always go back and resuture, or if you have a running suture, you can adjust the tension, and this can be based on the topography and the refraction that you do. How soon you can start removing suture? I think 6 to 8 weeks is the time when you can look at adjusting the suture by removing. If you have 16 sutures, maybe one suture, if you feel is tight, you can remove. But I believe that in the first 3 months, if you remove sutures, I always go back and if I have a tighter suture, I remove it. I go back and replace the suture, which is of optimal tension. Or if I feel that any suture has become loose, I remove that and go back and put another one. Now you have the Melonis intraoperative handheld, what you saw me use in the video, but you have these devices, the ring of lights that can be attached to your microscope, and they continuously give you the reflex. You can switch them on. And so even while you are suturing, you can look at that and optimize the tension in your sutures. Now, as we mentioned that when you see a reflex, your reflex is not round. So how do you, so always remember the short axis is the steep axis and the long axis is the loose axis. So that means if you see an oval, go back to your sutures and see. So if you see, if you first of all normalize the IOP. With the normal IOP, if you see a reflex like this, go and see in the long axis. If you feel, just go with your tying forceps, hold the suture and try to move it. If it looks very loose, that's the culprit. So you need to go back and replace. But if you feel that those sutures are optimal tension, then it is likely that the short axis, the stitches which are on the short axis are tight. So then you need to remove those sutures and replace them with lesser tension so that the reflex becomes circular. If you have a running suture and you see this kind of a reflex, then in the short axis, you need to move sutures from the long axis. That means where it is loose, from that axis, you start pulling the suture towards the short axis so that you can loosen the short axis, and the long axis you can tighten and thereby get the reflex to become circular. As we mentioned that, yes, you start suture removal 3 to 6 months, use topography, refraction for timing. If my patient is seeing very well, although some surgeons like to remove all sutures after a year or between 12 to 18 months, if my patient is under my follow-up and can come back to me at a short notice and has very good refraction, I try to keep the sutures in as long as possible. But yes, if your patient is not under your follow-up, going away, then it's important that after a year, if you feel the wound looks reasonably healed, you can remove the sutures. So all the suture-related complication of broken sutures, rejection, vascularization, or infection, these can be minimized. So the key takeaways of suturing is that it's a critical step for successful outcome in corneal transplantation surgery. Get the right instrumentation. That's very important because if you don't have the right tools, sometimes placing sutures can be difficult. If your tying forceps are not great, they are slipping, then you cannot optimize the tension. Or if you don't have a tooth forceps that hold the cornea properly, it may be difficult to take the optimal bite. Or if you're using a suture material or the needle, which is not spatulated or sharp enough, then sometimes passing the needle through the cornea can be a little bit more challenging. So you should prioritize equal depth, tension, and centration. It can be minimized by using optimal surgical suturing techniques and use of the keratoscope. And whether you use interrupted, continuous, or a combination of both, this can be based on the indication. Sometimes when I do very large diameter graft or repeat corneal transplantation or pediatric patients or eyes with peripheral vascularization or with OSD, I always prefer to put interrupted sutures. So continuous sutures you have to do only when you feel that these sutures are not likely to become loose in the immediate post-operative period. Because if they do become loose or they cheese wire, then it becomes a big problem because you cannot do any selective suture removal. You have to take out all the running suture and then go back and again place interrupted sutures. So I think this is in short about suturing in corneal transplantation surgery. I'll be happy to take up questions and we can discuss, and I can stress on any points that we have put in this presentation.